Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hello, everybody. This is Dr. Sandy Newist from the Living Medicine podcast, and I am excited to be here with Dr. Will van Derveer from the IPI, the Integrative Psychiatry Institute, which is a lovely training program that I'm excited to kind of learn more about. And the Living Medicine podcast is sponsored by Living Medicine Institute and the Psychedelic Provider Network, which are businesses that provide content and resources and training for clinical and medical professionals who are interested in psychedelic-assisted psychotherapy. So, Will, I want to welcome you, and I'll give a kind of a nutshell of your extensive bio. So, Will is a pioneering psychiatrist who, you mentioned this when we talked, became discouraged by the conventional medicine healthcare that you were trained to provide. And after 2 decades of working to develop innovative approaches, in 2018, he co-founded the Integrative Psychiatry Institute, also known as IPI. And you have this ambitious goal of training 10,000 providers in psychedelic-assisted psychotherapy and other innovative approaches by 2028, which I commend, but it seems like you are well on your way. So welcome, Dr. van Derveer, and I really appreciate you being here.
Well, thank you, Sandy. It's a pleasure to be here with you.
Good. Yeah. Well, many people, I mean, myself included, have ambitions of really establishing a training program in the space, and you all are doing it. I mean, you're like leading the curve. And I have known many people through the years that have gone through it and really speak really highly of it. I'm aware of the fact that it's very comprehensive and very rich. So thank you for what you all are doing in the field. I appreciate it.
Thanks, Sandy.
Yeah. And I just always like to start off by just asking, you, like, what is it that really drew you to the field? Like, what is your kind of origin story about how you come to be here as a co-founder of one of the largest, training programs in the world? Like, what got you here?
It was a combination of professional and personal, I would say. On the professional side, as you mentioned earlier, I was just more and more discouraged with the limitations of what conventional care could do in my work with my patients. And I kind of made forays out into integrative medicine, and that helped. In other words, running gut microbiome tests on people and hormone tests and, looking for occult infections, and all of this kind of functional medicine approach in psychiatry helped a lot. But there were still people in my psychotherapy practice who I couldn't help get home. And I say get home, meaning get back to nervous system regulation and, that kind of dynamic equilibrium and resourcefulness that allows you to roll with life's punches, And so when I got invited to become a MAPS researcher with a team that was getting started here in Boulder about 15 years ago, I was pretty skeptical, to be honest. And then
really? Oh, that's interesting.
Yeah.
How did you end up getting looped into that then? I mean, it seems
it's funny. You and I talked about this the other day about so I guess I need to back up a few rungs on the onion and talk a little bit about the context. So I was doing this integrative psychiatry work, and I was a very devout Tibetan Buddhist practitioner at this time. This was like 20 years ago. And toward the end of that first decade of the 2000s, one of my friends in the Buddhist community invited me to an ayahuasca ceremony. And at that point in time, so this is about 3 or 4 years before I was invited into this MDMA study. And I really received a tremendous amount of healing in my work with ayahuasca, which took on a life of its own and became a really big part of my life for a number of years. And during that time, there was another physician in my community who made a connection with a Colombian shaman who would sometimes come through Colorado and hold ceremonies. And so my friend Jeremy, who sadly, he was an oncologist, an amazing guy, died of cancer a few years ago. Anyway, Jeremy approached me and said, "Hey, would you be interested in talking to this team that's putting together an MDMA study?" And I had this attitude that, plant medicine was one thing and chemicals made in a lab were another thing, and that they were very different.
I've had that conversation many times.
And so, but on top of that, I'd been taught in medical school that MDMA caused holes in the brain and it was a drug of abuse and there was no medical use for it and so on. So when I first talked with Rick Doblin about this opportunity 15 years ago, he straightened me out that the George Riccardi paper that the holes in the brain story came from was actually a retracted paper. And it got retracted because Riccardi's research team had flipped the labels on. So they were using a very high dose amphetamine comparator in this study of monkeys.
Yeah.
And the monkeys who got high dose amphetamine actually had holes in their brain, and then the ones who got MDMA didn't, but he had it flipped. Anyway, the impact of that study was huge, even though it got retracted.
It was huge. Right.
So people like me didn't know that it had even been retracted because the impact was there from the first study. Yeah. So it was my friend who was, like I said, was a physician in town. He encouraged me to actually read the research on MDMA therapy rather than just throw the baby out with the bathwater.
So here's the actual research where they didn't mess it up.
Exactly. And so Michael Mithofer had recently published a paper at that time in 2011 that showed that 83% of the people coming through this protocol no longer met the criteria for PTSD. And that just blew me away. So that turned the corner for me. And, I got involved and I saw what was happening and how quickly people could get well. And I was able to even refer a handful of people from my own practice into the study and watch them get the results that they couldn't get with me in ordinary therapy, which was mind-blowing and humbling. And so it became evident by the time we were wrapping up that trial that I needed to do something about this because I couldn't really just go back to my ordinary therapy practice and just carry on. It felt like an ethical crisis, actually, to not provide psychedelic therapy after seeing how effective it could be.
Yeah. Huh. That's so interesting. I mean, I feel the same. Maybe we can kind of give ketamine a mention, later as we talk, just because that's primarily what I work with. And, I find myself just chomping at the bit, with, like regular traditional psychotherapy. Just, there's a lot of stuff around access and how do we get there and things. But once you've seen really profound results, it's really difficult to not get behind it. And
absolutely. So that was the professional stream. And then the personal stream was my friend who had introduced me to ayahuasca kind of opened a door in my spiritual development and my healing path where ayahuasca became an important part of my life. And for a while, again, this was more than 10 years ago, I had become convinced that, I was going to leave psychiatry again. And this time it was going to be for good. And I was to become an apprentice.
I'm super done with this.
Traditional, indigenous medicine is the way to go. And every time I went to ceremonies and asked for guidance about this, the result was, what, we have enough apprentices down here. You're a bridge. You can help. Let's bring this deeper root cause, expanded consciousness approach to healing into the mainstream. And, you can play a role in that. So I was pretty disappointed by that message because it felt really complicated to function as this bridge.
I just want to move to the jungle.
Exactly. I
thought that's what I was going to get to do.
Exactly. So, but every time I went back, the message was clear. Just like I already told you.
Interesting.
Yeah. Go back and do your job. And so here I am trying to carry that out to the best of my ability.
So for people who haven't done plant medicine or done a deep dive into psychedelics, that might sound, a little atypical, right? That I was summoned in these spiritual ceremonies to do what I'm doing now. And yet I've heard many people say that. And actually, that's been a piece of my own experience as
Mm.
well, working with the same sacred plant, using different kind of prayers, the Santa Daime, which is ultimately what has led me to here.
Okay.
And so I'm just curious if have you also heard a lot of other people say that? Any thoughts on that phenomena that you feel comfortable sharing? It's quite an interesting commonality, that is really found by a lot of people who have staked their, place as professionals in this field. What are your thoughts?
Well, I do think that there are many people in our field who are uh, operating, from, I don't want to, I mean, to me, it feels a little strong to call it guidance, but like from a deeper place of wisdom that I feel is ultimately a non-local kind of wisdom and intelligence, a consciousness that is within us, but it's not our wisdom necessarily. It's a collective wisdom that is in us and outside of us both. Um, and people don't tend to really talk about it much because it sounds a little I don't know, hokey, or maybe could be like interpreted as like a Pollyanna kind of, new age idea, or but it's a quiet um it's a quiet calling that I think it's helpful for people to talk about it. And that's why, I'm showing up here and talking about it, is that
Yeah.
I think it's important for us to acknowledge that in a materialistic culture. And what I mean by that is not that people are going and buying things. I mean, that's part of it, but I'm talking about materialistic as in, if we can't see it, touch it, measure it, then it doesn't exist. That kind of materialism.
Well, so many of us were also taught that. I mean, I'm not a
Yeah,
physician, but I was trained as a psychotherapy outcome researcher. And,
right.
we're taught like it must be measurable
Yeah,
in order to be validated. And while other things may, in fact, be informing it, if it's not measurable, then it's not part of the scientific method, and don't really talk about it because then it's
exactly.
not a relevant construct.
Exactly. And that kind of reductionism extends into the phase 3 medical trial, that is the sort
Mm,
of the holy grail of medical research, right? That has to
right.
be, by definition, it's reductionistic.
Yeah.
Uh, so it leaves out what we call real life situations, right? Like a person in a PTSD trial doesn't only have PTSD, they also have, all the things that go with that, all of the
Yeah.
life problems that people face as being human. So I
Hmm.
think that if we try to erase or cut out the mystery, or the things that we don't understand about spirituality, or about connection, or about the universe, then I think life becomes kind of antiseptic. It can
Hmm.
feel pretty dry, and
Hmm.
it also cuts out a resource that I think myself and a lot of people need to feel grounded in the experience of being human, to face all the
Yeah.
things that we face.
Well, and it's interesting because, as you're saying it, like, and I'm curious what, having devoted, a significant portion of your life to not only ceremony, but also, Tibetan Buddhism. And I can only assume like, consciousness expansion and mindfulness
Right.
and what that means in terms of it. As you say it, it's like kind of just leads me. I was kind of pondering like what the role of, I don't know if consciousness expansion is the right word. It's stereotypical, but it seems still like a good one, in mental health? And is it possible that all of our reductionistic ways of working with mental health and not allowing that are actually one of the reasons why our mental health system isn't really working?
Right.
I mean, can we go there? Has this kind
Right.
of led us to that frontier, not just in this
Right.
interview, but in the field?
I totally agree with you. And, you know, I mean, there's a lot of, it's kind of easy to poke holes in our mental health system. There's a lot of problems with it, but I think that is one of the really big problems.
Hmm.
Um, that it's kind of cool that some of the research that's coming out, like Robin Carhart Harris's work, and um, Gold Dolan's work, and some of the other groups, are looking at like what's really going on when a person's sense of self or their separateness dissolves into this bigger,
Hmm.
more diffuse point of view. And what, in contrast to that, what's happening with chronic depression? What's happening with rumination or OCD, or these deeply locked in kind of mental cages that people can live in? And we're learning that kind of capacity. I'm reminded of one participant in this study we did, who said on the MDMA, like, I can actually see the forest for the trees. Like I'm above the forest of my mind and I'm looking down and I can see it. It's a different point of view. And it's such a huge opportunity for remodeling our beliefs and our experience and so on. A lot of integration necessary, but when we're, it's like when you're in the forest, you don't even know that there's another opportunity because it's so dark in there and full of thoughts. Yeah.
Right. Yeah. Yeah. It brings to mind, one of the things that I'm pretty intrigued in is state versus content. Like you mentioned nervous system regulation. And, to me, that's kind of we get so bogged down in the content that we don't always realize that it's a state, and that our physiological, psychological and emotional state is driving the thoughts and the mind, which is kind of where we start to get into that mindfulness, relationship. But, I think when people are really traumatized and their nervous systems are super activated, it's really difficult to see it as a state and to develop that capacity to observe and witness.
Totally agree. Yeah. And then when the state changes, there's an opportunity that's like it can become like a beacon, like a light in the fog that you can, chart your course toward to, strengthen and develop and deepen and broaden that experience to make it more stable, right? The more expanded perspective. Yeah.
Yeah. And how do you think your own practice with Tibetan Buddhism and, ayahuasca, since you mentioned it, and other forms of, consciousness exploration really informs, who you are as a teacher and an educator and a physician and a trainer, these days? How does that inform your current work?
Well,
those practices.
Great question. I feel like the dilemma that comes that I kind of face, I feel like on a daily basis, is how to have ambitious goals and how not to get hung up on the outcome and how to be with the process. And I think that my Buddhist training and my experience with plant medicine really helped me learn how to remember to be more present and to not get so wrapped up in the outcome, and to remember that the things that we're working toward, there's so much more involved in the thing manifesting than just our own effort. Even if we're very effective in our role or how we define that, I don't know, maybe I have a 5 or 10 or 15% impact on, the sort of like the manifestation of it. And so it's humbling, but it's also really liberating to not take on, and certainly have the moments where I do take it on, but these moments of like, I'm 100% responsible and I take all the blame for, the fact that it isn't widely known or accepted, or a household name that, this kind of work for healing can be accessed by people, as you said earlier, even already with ketamine, right? In the right situation. Yeah. Not that many people know about it still.
Right. And it's super interesting. I mean, this could go on for hours, right? But just even the kind of like exposure pieces about, like the way in which language kind of informs our capacity for growth, and exposure and what we're exposed to, informs our capacity to kind of see outside of the boxes that were created. I don't know if you know Dr. Keith Heinzerling. He runs the Pacific Institute for Psychedelic Research in California. And
not yet.
He was a podcast guest, and he's also he's also a practitioner and very into the consciousness exploration, and also a researcher and a physician, and all of those things. And so part of a group of people who kind of sit and ponder these things that are scientists. And, so it's very interesting study. And especially when we get into the way in which this actually does influence mental and psychological health.
Yeah. Well, it seems like pretty clear in the research that having experiences that take us outside of our rabbit hole that we normally occupy in our mind,
Mm-hmm.
no matter what the cause is, it doesn't have to be psychedelic, right? It could be a near-death experience. It could be uh, a brutal kind of sudden loss of a loved one. It could be any number of things, a sudden illness that we experience personally, that these things can rock us in a good way that kind of fractures the habitat that we normally live in and think of as who we are or what our mind is, and get us outside of that and help us to see this more this perspective where we're not as certain about what life is or who we are or who the people around us are. So there can be more we can see more possibility.
Mm-hmm. Mm-hmm. Yeah,
Yeah.
I love that. So, how do you think that relates to psychedelics? Like, why do you think psychedelics are such a powerful tool for working with mental health? What is it about the altered state? Does it relate to this consciousness piece? Are there other mechanisms? I know, again, a huge question, but you've been involved in the field in a long
Mhm.
time and in a lot of roles. And I think
Yeah.
it's really an interesting question, like, what is it about the altered state that supports this type of change? And again, that can kind of lead to the different types of medicines, which, if we get
Sure.
time, would be interesting to ask you too.
Yeah.
But what do you think? What is it?
Well, my personal view, and as you said, that there's a lot of different threads of research about a lot of different potential mechanisms. And I, as an integrative medicine person, I love the whole story about inflammation and what's happening biochemically in the brain and so on. We could talk about that, but to me, where the real money is in terms of the value of investing in this kind of work as a client is that our the structure of our thinking is a reflection of what we've lived through in our lives.
Mm-hmm.
And most of us, and I say us because I personally have a pretty high ACE score on my ACE questionnaire. Those of us who have had a lot of, especially early trauma,
Mm-hmm.
you tend to have, relatively speaking, a bigger presence or burden of negative thinking, obsessive rumination, anxiety thinking, worry, that kind of thing, that prevents us from accessing this bigger, I call it divine
Mm.
self, and a self that is not separate necessarily from this more expansive consciousness that is within and outside of us. So when we are able to deliberately provoke a kind of temporary disintegration of that jail that we live in,
Mm.
and we find out that it in fact is just a jail that just dissolves, like you can do,
Mm-hmm.
like that's something that can happen so easily with
Mm.
these tools. Then we can actually begin to redefine who we are, and we don't have to be limited by our negative beliefs and think that,
Mm.
okay, well, this is just who I am. It's like I'm a person having this experience.
Yeah.
And so to me, that's kind of maybe more of a spiritual take on the potency of these experiences. But to have a tool that we can use to deliberately uh, seek to exit the cage for a period of time,
Mm. Oh,
I
I
think
like that.
is incredibly, incredibly
Yeah.
powerful opportunity.
Right. Yeah. Tools to exit the. Can I write that down? That's very cool. I like that. No, it's true. Like, how can we get out of the cage of our own thoughts that are, created by? I always say to clients and trainees, every single experience that we've ever had up until this moment influences the way we're experiencing this moment, and this moment will influence the rest. Like our
Yeah.
brains are meaning-making machines. So, to be able to free ourselves from that nervous system and thought-based and experiential lens that is scanning the world for threat based on previous experience, and to have that shift, I think is really, really big.
Yeah. Yeah.
Mhm.
It's really exciting. And
Yeah.
yeah, yeah, it's an incredible opportunity.
Yeah. Well, so then that leads me to the training piece. Like you have trained many folks at this point. Like how many people approximately do you think have gone through the IPI
I think
trainings?
we just, our last cohort, we crossed over 2,000 people. So I think we're at
Nice.
2,200. Yeah.
You're getting there.
Yeah.
You're
Getting
getting
there.
to your
We're on our way.
10,000 goal. Good job.
Thanks.
um, well, so, kind of, I want to just start broadly and then kind of get to what, what your thoughts are the most critical things and what you want to, what you would like to speak to. But what are some commonalities that you see in the people who are drawn to this work? I mean, from what I understand, IPI does, clinical and medical professionals, just as we have done with Living Medicine Institute. Is that correct?
That's right. Yeah. That's
And that
right.
they're mostly in the same track. Is that right?
Yes, that's right.
Yeah.
So only licensed providers. Yeah.
Okay.
Yeah.
So what are some commonalities when you kind of reflect on, obviously, I know you don't know all, 2,200 of those people,
Yeah.
but, but what are some commonalities that you see in the professionals who are drawn to this work?
Well, I think there's been an interesting shift, I would say, over the 8 cohorts that we've run. In the beginning,
Mm-hmm.
I would say almost everyone I met in the beginning had a personal path that had something had happened, whether it was experiencing plant medicine or near death experience or something that caused them to sort of permanently question the assumptions of conventional psychology or the care or what they were trained in and so on. And so those people were, I would say, early adopters, people who had a personal conviction or they had a family member or a friend who had gotten well in this way or something like that. Not everyone, but there were more people in the beginning like that. And now as the work expands, and I think we're going into more of the mainstream, this more professional stream is showing up more of people feeling really disturbed and burnt out by in the way that I was, in the beginning when I quit psychiatry only 2 years into my practice because I was so disturbed by how limited the tools were. So there are, when you're looking for a place to start a revolution, it works well if the people you're speaking to are very unhappy with the current circumstances.
Would you say that you were looking for a place to start a revolution? Would you come right out and say that?
Well, I mean, I'm playing my role. I mean, I don't want to
Right.
overemphasize that, but
No, but I mean that's kind of what you were, not
well,
great.
yeah, I mean,
Right.
it's incredibly disturbing. I've had people take their life under my care who needed certain things that I knew that they needed, like ECT, or whatever the thing was that they needed that they couldn't get in the system. And we have not to go too dark here, but there are dozens of people committing suicide every day whose lives could be saved by these tools. So it's just incredibly disturbing. And so we have a lot of people now coming into the work who are simply fed up with the conventional approach, but they're also not, they don't consider themselves to be like these renegade rebels who are going to go, work with Schedule 1 drugs and break the law, and risk everything for that. So it's necessarily a slow process, but it's a lot slower than, many of us would like to see it go.
Totally. Yeah. I mean, I thought I got into ketamine work thinking that I was kind of just in the queue to start working with MDMA.
Sure.
Because, the clinic that I was working with was kind of in on the list for expanded access. And that didn't end up happening for a lot of different reasons. And, came to really come to deeply appreciate the clinical utility of ketamine along the way. So I'm not one of those like radical, like, I'm going to do it underground. And there are plenty of people who do that and more power to them. And they're certainly a part of this, moving this forward, but that's not my thing. I'm going to stay, and fully in the legal lane. And so you're saying that in the beginning, it was people who had an experience, whether it was, through psychedelics or some other, really intense, not ordinary state, such as near death. other places in which they'd seen, kind of expanded visions of reality and were really being drawn to this work. And,
Yeah.
what do you see now? Do you see more people who are just interested? Like, what's the pull now? I mean, of course, those people are still coming.
Yeah.
But what about others?
Well, I'd say it's shifted from like a 80-20 in, 80% of folks who had some kind of personal connection to the work, or had been following MAPS or been involved with MAPS for years and so on. And then now the 80% is folks who are facing the reality that our mental health care system leaves way too many people up a creek without a paddle, and they want better tools. And
Yeah.
most of these people, which is really exciting, have never had a psychedelic experience personally before.
Interesting.
And
Most of
so
the people who come to your program really
I
at
would
this
say
point.
so. Yeah, at this
Oh,
point.
fascinating. Ours is probably 50-50.
Okay. Yeah. So what's cool is, they not only do they get to learn, the way to do this, but they also, in our practicum experiences, they've been able to have these experiences
Yeah.
personally. So
Mhm.
that really changes the game, of course. It's like the difference between reading about playing basketball versus like going and playing basketball. It's like it's not
Mhm.
the same thing. Yeah. Yeah.
Yeah. Interesting. Yeah. So, you've done a whole bunch of this at this point. So, you know, what what are the critical things, that you think practitioners really need to know? Um, kind of in general. And then I'm going to ask you, like, what is your thing? Like, what do you want to, kind of teach? Like, if you were taking over, like, what would your
Mhm.
message be? I mean, obviously, I get that it's a collaborative venture, but what's your voice? Like, let's just start with if somebody wants to get in the field, what are the critical things they need to learn? And then I'll ask you more about your own thoughts.
Well, I think there are a number of different areas that people need to learn in.
Hmm.
And so we have different modules that cover those different areas. I mean, psychopharmacology is one area. Um, the sensitivity and cultural humility that goes with
Mm,
honoring indigenous traditions is really important. The ethics of providing care and even supportive touch in these highly suggestible and sensitive states is really important.
mm,
Um, the what the tool set is for preparation and integration. Why integration is pretty much the whole game. I mean, sure, the dosing session is important, but the integration is critical.
mm,
Um, there's so many different aspects, but if I had to boil it down to one thing that people
hmm.
providing ordinary mental health care often don't get, and they don't get it not because there's a problem with them personally, or they have a character issue or anything like that. It's just a
Yeah.
matter of how busy mental health care is, and what our training is teaches us that we don't have time to be curious about people.
Mm,
We have to get to a diet. And if you're a psychiatrist, you're going to write a prescription on the first visit, right? So
right.
you
In a
damn well,
very limited period of time.
very limited, like 30 minutes, right?
Right. Yeah.
So you don't have any time to be curious about this person. You're
Yeah.
checking that. I want to get that 5 out of 9 boxes on the major depressive scale done so I
Right.
can
Check, 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 check.
SSRI. So what is critical to unlearn, and what I had to unlearn, is how to stop racing to a conclusion about what's happening or what the
Mm,
person's experiencing or what they need, and
yeah.
stop trying to say something really smart
Oh,
and
interesting. Uh-huh. I
it,
love that though. That's a
provide.
big deal.
It's a big deal.
Hmm.
We have to learn how to get out of the way and really trust this, what MAPS calls the inner healing intelligence, this
Hmm.
capacity for the human to know, to tap into that wisdom we were talking about and get the answer with very little interference from the therapist,
Yeah.
as opposed to, and I guess this is particularly a problem for people like me as a psychiatrist, is people are coming for answers. They have
Mm.
questions, you have the answers, and then the transaction is, here's my payment for my session, I want the answers. um,
It's so interesting. I always kind of joke with my MD friends. I'm like, y'all are like trained to be like the authority. Like,
right,
for better or
as
for
if,
worse, right? You need to
right,
have the answer.
right, yeah,
And
it's a big problem. So
Mm-hmm.
you can easily become a bull in the china shop in a psychedelic session if you're taking that attitude and you don't
Yeah.
even know it. You don't even know that you're polluting the environment that the person is trying to heal in.
Mm-hmm. Well, it's so interesting because I'm a psychologist, so I'm not a psychiatrist, but I had, sort of what I now consider a real gift of working for like decades in private pay residential treatment centers and outdoor treatment centers where people actually paid a decent amount of money. Decent meaning I was able to make a living at doing full on comprehensive psychological evaluation with personality assessment and cognitive
Cool.
assessment and symptom assessment and create a case conceptualization.
That's great.
And at the time, I didn't really realize that that was really an anomaly.
Yeah.
Because then when I moved into other settings, I was like, I can't possibly do this in like an
Yeah.
hour. I
Right.
could do
It
a
feels,
diagnostic formulation, but not a case
yeah.
conceptualization.
Yeah. Yeah.
Um,
That's
and
great that you
for
had that
those listening,
experience.
that means like what is driving the symptoms, like that's what that
Exactly.
means to me. Um,
Exactly. Exactly.
and it's such a big part of, I think, like, because I was initially taught to do kind of preparation, like 2 sessions, like preparation was all about getting ready for the medicine, and the name
Yes,
itself implies that.
it does. Yeah.
But this, what you're saying, and I think I share that, is really extensive preparation is about establishing a relationship and a case formulation, if we're going to use that language within the
Right.
context of the relationship. So you can both help and support, but also know them well enough to get out of the way at the same time and not have the answers. So I'm
Right.
just curious, what that was me talking instead of you, but what are your thoughts about that? Do you share that or?
Well, it's interesting. We, as a pragmatist, I think I balance, right? Like, okay, how much does that cost? Like, is it going to
Mm-hmm,
prevent certain people from accessing the treatment?
mm,
If the sort of mandate or the professional norm is, okay, we're going to spend 10 or 20 hours doing preparation versus, 2 or 3 hours.
right.
And so I think what might be more practical in terms of mainstreaming this work is what we're already seeing. Like, for example, in our ketamine work with people, we might do 1 or 2 preparation sessions with our ketamine therapist and then go through an intensive series of ketamine work with our
Mm,
therapist. And then the person goes back to their non-ketamine therapist
mm-hmm,
for ongoing longer term integration work.
mm-hmm.
So there can be maybe a little bit more of a balance of that. Uh,
Like, so you're saying it depends on whether or not they have access, whether or not they can afford it, whether or not they've got a referring,
exactly.
therapist who they're going to go back with, that they already have an
Exactly.
established relationship.
Yes. But
Mm,
what you're saying, I totally agree with, is that if you only do a couple of sessions ahead of time and then the person has a really big experience, and your protocol is, okay, well, we only do a couple of integration sessions, a person can be left very fragmented and
yeah.
can be traumatized by the work that we're doing
Mm-hmm.
if there's
Mm-hmm.
not
Yeah, I
enough of
agree
that
with that.
holding. Yeah.
Yeah, and just to be clear, for me, when I say, more than a couple preparation sessions, I'm really talking about like 3 to 5,
Okay.
not like
Yeah.
20 unless the client
Yeah.
has the resource and wants to do
Right.
that. I would say
Right.
for me, my norm is probably 4,
Yeah.
and I switched from kind of early on when I would do 2 because it was often kind of driven by the clients, like, let's get to the
Yeah.
medicine, let's get to the
Right.
medicine,
Right.
you know.
Absolutely. And
So
there's that. I'm glad you brought that up. That's a whole nother piece of education that therapists need, is like addressing expectations. Right.
hmm
And in the ketamine work, for example, it's so common for people to feel like, well, the chemical is really the issue, right?
yeah.
It's going to help me. The ketamine will make me feel different, as opposed to
hmm
the ketamine will be an ally to help me do the deeper work to discover how these mechanics got in place that I need to undo through the integration.
Yeah.
So if we don't educate people properly on the front end, then it's a real setup for disappointment, because, as you know,
hmm
ketamine's chemical effects are gone within about a week in terms of the impact on the default mode network and some of the inflammatory benefits, post anti-inflammatory benefits. So we have to really prepare people for, like, hey, this is a catalyst. This is going to create an
hmm
opening. Sometimes I call it a tow truck to get you out of the
I like
ditch.
that.
But you're not going to want to ride behind a tow truck for the rest of your life,
Right.
right? With
Right.
maintenance
Yeah.
ketamine. That's
Yeah.
it's a little bit of a pet peeve of mine that people are using maintenance ketamine with their clients without doing enough integration work.
Hmm. Yeah. I have a whole caseload of people that do, I call them booster ketamine, but we
Mm-hmm.
do psychotherapy in between. And
Yeah,
granted, that's an access issue and it is costly. Like I fully acknowledge that. And it's an
right.
interesting kind of experiment and, a growth edge to be exploring, like what is the role of long term and,
Yeah,
frequency and all of those different things. It's kind of a moving target.
it
So,
is. It's very
yeah.
confusing.
Yeah, so you are uniquely suited to speak to kind of the magic question of one of the magic questions, which is MDMA versus psilocybin with maybe, ayahuasca living out there and, sacred plant medicine land and, MDMA and ketamine. Like, it sounds like you have facilitated all of these things and teach about all of those things. I know in the program, whether you do or the program does, but just,
Right.
what are your thoughts about that? And if there was a world in which all things were legal and accessible, which they're getting closer in Colorado than most places,
Right.
what are your thoughts? Not
Uh,
necessarily hierarchical, but is there, I mean, it could
right.
be. Like, do you have a preference? Is there a place and a time for all? Like, what do you think about that?
Well, I think about this a lot. So
Uh-huh. Yeah.
I think each of these has, they're different tools, and it's kind of like
Mm-hmm.
having a hammer and, a saw and maybe a rake in your garage and, use them for different things. So with one thing I really like about ketamine is its very acute anti-suicidal thinking benefit.
Mm-hmm.
I don't see that with these other tools as
Yeah.
in the same way. I mean, but then of course ketamine has this big drawback I just mentioned of, typically the benefits evaporate pretty quickly.
Yeah.
So I can see the role of ketamine in the future when all things are available. I
Mm-hmm.
say that rather than if all things are available, but when things
Right.
are available.
Right. Yeah.
As something that we would probably in a more acute setting, like an emergency setting, we would probably use ketamine. But the
So
drawbacks of
for specific for suicidality, like,
suicidality,
okay.
very severe depressive symptoms that can
Mm-hmm.
change dramatically. I mean, 50% reduction in the severity of symptoms in 24 hours is not uncommon with ketamine. It's
Right.
very
Right.
impressive.
Mm-hmm.
But I don't think long-term ketamine uh, is our first choice. I mean, I'm not saying
Mm-hmm.
that it's bad or wrong. I know some people need that, and they've tried a lot of other things, and that's the only thing that works for them. Uh,
Right. And in some states, that's what's going to be
right,
legal,
of course,
So,
absolutely,
mm-hmm.
totally. But if you look at what psilocybin can do for depression, 1 or 2 doses, keeping the boogeyman away for 6 to 12 months is pretty great,
Mm. That's pretty great.
and especially when you look at the sort of maybe potential toxicity or risks of psilocybin. I've never met someone addicted to psilocybin. I've definitely met people addicted to ketamine.
Oh, for
So,
sure.
so there are things that are pros and cons between, and we're just
Mm-hmm.
talking about depression right now.
Mm-hmm.
But then when you look at, well, what if someone's dealing primarily with trauma,
Yeah.
and a lot of people who are dealing with depression have trauma that hasn't been, adequately
Right.
surfaced yet. But if the presentation is trauma, then it seems like MDMA has a much more supportive and less unpredictable impact on people. And it's just the chemistry of MDMA and
Mm-hmm.
oxytocin and this interpersonal connectivity and trust and diminished fear, and the whole thing with MDMA is very different.
Mm.
And 1 to 3 sessions with that for even severe trauma can be incredibly dramatic in the long-term
Mm-hmm.
benefit. So uh, I think that these all have different applications and uses. And as far as ayahuasca goes, I mean, I consider that to be more of a spiritual
Mm-hmm.
practice. Like you mentioned Santo Daime being like it's actually a religious ritual, right? It's an
Mm-hmm.
experience that isn't necessarily, it's not definitely not tailored for, okay, this is a treatment for a condition, right?
Right.
Unless you want to call it the human condition, which
Yeah.
so,
Right.
So I think that the intensity and the challenges and the kind of you're on your mat by yourself kind of vibe with traditional
Hmm.
ayahuasca ceremony is not something that I would ever encourage someone with a mental health condition to go directly to. I think
Right.
it can be very powerful and very helpful, but it also can. I've just treated too many people who were dealing with something significant and went to the jungle and had a really hard experience, and then took a year of intensive therapy to integrate that experience.
Hmm.
I think it would be much better to start in more of the shallow end of the pool than that.
Good. I appreciate you making that, like so clear because people pop up and they're like, this cured me. But like a
Mhm.
lot of times they're not speaking to, how many steps that were done along the train to get there, or maybe they're
Yeah,
the anomaly. I've seen many people be damaged
yeah,
and kind of left, just essentially flailing about without appropriate integration because things come up and they're unintegrated and they're not supported. So I
yeah.
appreciate you
And
raising that.
it's also not really a part of the traditional indigenous practice to do
Mm,
really any integration.
yeah.
And maybe that's because traditionally people are all in the same community, and you're keeping an eye on people, and maybe
Hmm.
there can be some care if someone needs something. But
Right.
the other big issue that I don't want to go on and on here, but with ayahuasca, you have this MAO inhibitor that's a part of particularly the vine component of the tea, and it's quite dangerous actually for people on antidepressants to drink ayahuasca because of that interaction.
Mm, hmm.
Can cause a kind of a medical crisis. So
Oh,
um, the things that is another benefit. I'll go back to ketamine, that because it's
right.
not a serotonin drug, it can be combined with what a lot of people are already taking for their mental health condition
Hmm.
quite easily.
Yeah.
Um,
So you don't have to go off the meds. I mean, I
yeah.
always add it's easy to fit into a clinical practice.
Yes.
It's legal nationwide.
Yes.
I do mostly IV, so it's really predictable. Like, you can have people
Fantastic.
come in and out in a 2-hour session, which again is amenable to a clinical practice. And
Yes.
so I've been kind of, running the experiment for a while, about doing, like infusion series plus psychotherapy, which would
Mhm.
mean, 6 to 8 sessions over, 3 to 6 weeks, depending, um, with some follow up. And, I'm just curious, like, what are your thoughts? Do you think, like, I'm working the hypothesis that yes, I'll just own it, but it's a hypothesis, it's a work in motion. I'm not gathering extensive data, but, do you think that we can skin the benefits that way of ketamine and get past that week-long window? Is that
Yeah.
what you're seeing?
Absolutely. Yeah. We did. I say did because we're focused on our trainings and not providing direct care anymore right now. But
Yeah,
we
right.
did it exactly the same way you're talking about, of 6 to 8
Hmm.
sessions IV, with a therapist in the room, the entire time, with preparation and integration. And we didn't have a huge number of people. We had about, I think that the statistic was around 10% of people who came back
Yeah.
for boosters. Um, but and that was, several thousand people that came through our protocol in our clinic. So we felt pretty good about that,
Yeah.
as a kind of counterpoint to maintenance ketamine. Um, but
Hmm.
it's interesting because it goes again back to the preparation conversation of, like, anyone listening to this podcast who's a clinician who works with terribly depressed people knows that it's going to come off very tone deaf to go to a depressed person and say, hey, let's get you exercising, let's change your
Right.
diet, it's going to be great.
Right.
It's like,
All you have to do
what?
is this. I swear.
No way.
Right.
um, you'll be lucky if they don't complain about you on
Right.
Google reviews or something.
Right. They just tell me to exercise as if I can.
But it's different when you say, look, we're going to do a 6 series of IV ketamine with therapy. We've identified in these 3 or 4 sessions or 5 sessions ahead of time that your diet stinks, your level of exercise needs help. It's all because of the depression, most likely.
Hmm.
So what we're
Hmm.
going to do is we're going to make a plan that is, as you begin to feel better, we're going to start working on these foundational health issues that you can't bypass these things.
Right.
You can't eat at
Yeah.
Taco Bell and sit on the couch every day and think that you're going to have good mental health. It's just not going to work.
Right. It's not going to
Um,
happen.
but
Yeah.
if the view of the patient is, well, the ketamine's going to fix me, and if I'm feeling, my PHQ-9 is, back up from, it went down to a 5 during my work, but now it's a
Mm-hmm.
10 or a 15. I better go get some more ketamine. Like it's just the wrong view.
Yeah.
To not also engage these necessary pieces
Mm-hmm.
of
Yeah.
health.
I agree. So we got a couple minutes, and then we'll wrap up. And so, the last two things, and you can take them in whatever order or whatever you want to say, is kind of like, if there was number one, if there was anything else that you'd like to really just kind of like teach as a, senior educator in the field. You talked about that piece about how do we kind of, get out of the way and stop holding the knowing, which I think is really critical.
Yeah.
And and then there's this piece about what is IPI up to? You all launched a new program, and then how
Mhm.
do people find you, and anything else you kind of want
Yeah.
to get out into the field?
Thanks, Sandy. Uh, one of the biggest gifts that I've had the privilege to receive from people like Bill Richards and Mary Cosimano and Michael and Annie Mithofer and some of the Marcella and Bruce here in Boulder, very experienced psychedelic therapy providers, is this kind of relentless curiosity. This
Mm-hmm.
uh, kind of staff in the ground unwillingness to jump to a conclusion or rush to anything. And so this notion of multiplicity, that
Mm,
a lot of different things can be happening on a lot of different levels for one person in one moment, is so helpful. And
mm,
it's hard to teach that without people having experience facilitating sessions and having to work with their own mind. But when this is where the mindfulness piece comes in for
yeah.
trainees and for those of us doing the work, is having the capacity of a witnessing ego of, okay, I'm having a thought, I'm having an impulse to intervene here. Um, I want to go and offer this person supportive touch. Wait a second, they're
Mm,
not indicating that they need that. Where is that coming from? Okay, it must be coming
mm,
from me. I'm going to work
mm-hmm.
with my own mind and be over here and stay out of the way. And it's an art that it takes time to develop that capacity, but that's probably the core um, ingredient that I think I'd like for people in the field to have is this
Mm-hmm.
curiosity.
Just like stay in that curiosity. What
Yeah.
I heard you just say, tell me if this is right, is question what you're doing, question whether it's in the client's best
Yeah.
interest, stop. Like, why am I
Yes.
talking?
Exactly.
Is this really warranted? Where are we in the process of what, or is this just driven by me?
Exactly. Yeah.
So great.
Yeah.
I love that. So tell us about IPI. What are y'all up
Well,
to? You know?
so we, as you said, we've trained a couple thousand people. Uh, so far, everyone has gone through the entire year long training is how we've structured it.
Mm-hmm.
And we're finding out in 2025 that there are a lot of people interested in the work who are ready to make a first step, but not ready to sign up for a year long intensive program that's 300
Mm-hmm.
hours and $10,000 and travel and all the things. So we're launching a new format where we call it a level 1 certification, where people
Mm-hmm.
don't have to travel um,
Mm-hmm.
and get to participate in live online training and home groups, small home groups, and lectures that are live online, and lots of asynchronous learning. And then over time, we'll be offering additional levels,
Mm-hmm.
with practicum experiences and so on. Um, so we're just kind of surfing the wave of what's
Uh-huh.
seems to be happening right now, and
Great. I love
I,
that. Is that available currently? Like, are you signing people up for that? I imagine that'll have
we
a,
are,
fairly
yeah,
significant appeal. Like people can dip
yeah,
in and get those foundational pieces and then have the opportunity to continue if they want to choose to do so. I love
yeah,
that.
yeah. Thanks,
So
Sandy. Yeah.
Great. And I imagine you all are going to be at, well, actually, honestly, by the time this airs, this will be past, but we will all be at Psychedelic Science.
Yeah.
So, and again, I've heard great things about IPI. So, I highly encourage everyone to check that out. And anything else you want to share before we close?
No, it's been a great conversation. I really enjoyed the time with you, Sandy, and look forward to more in the future.
Me too. Well, thank you so much, Will. And I really appreciate your time and in sharing your wisdom. And thank you so much, everybody. Bye-bye.
Thank you.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.